Hello, everybody, and welcome to our Research into Practice webinar today. My name is Emma Wilson. I'm the Communications and Engagement Officer for Research and Innovation at Greater Manchester Mental Health. We're really happy to have you here today. We are here to hear from Addictions and Research team for the November slot, and we're really pleased to have them here today. So I will hand over to these speakers in a second, but I'll just introduce them first. So we have Dr. Stephen Kaar, who is our addictions research lead and consultant addictions psychiatrist at GMMH in the Chapman Baker unit, and Dr. Nikos Mylonas, who's a research associate within the addictions research team. So without further ado, I will hand over to Stephen to kick us off.
Thanks, Emma. Okay, so we're going to be talking through some of the work that we've been doing in the addictions research team and telling the story about how we started up as well. And just a few declarations before we get started. So I'm a kind of co-chief investigator with Professor Celia Morgan on the ketamine-assisted psychotherapy for alcohol use disorder study called Care, which is actually running in the trust at the moment and is one to be aware of. And more recently, I've also become a principal investigator of a GLP-1 study for alcohol use disorder with Lilly, which we're also going to talk about briefly today. So I'm going to give an introduction to the addictions research team. We've been doing addictions research in GMMH for some time. I came along about 4.5–5 years ago, and we started to kind of solidify the research, and I'm going to talk a bit about that. Then we're going to talk about some of our actual research findings, which you'll find interesting. So we're going to present some ketamine detoxification data on the CBU and some opioid detoxification in people with schizophrenia on the CBU, so some very timely COSUM data there. I'm going to talk through some of the other clinical trials in addictions in GMMH, including those ones that I mentioned before. And then Nikos is going to take us through two of our NIHR-funded studies, which is first the VALOR study, which is the value of assertive outreach, where we looked at the alcohol assertive outreach model, and we did a mixed methods analysis in Bolton and Salford. And then the EDITH study, which is the early detection in liver fibrosis, which again was a qualitative study of a new pathway for detecting liver fibrosis using a fibre scanning machine in the Rough Sleepers drug and alcohol team in Bolton and also Salford. So obviously there has been addictions research going on in GMMH for a long time, but part of the reason why I was invited up to Manchester to start this job was my background in research and my previous PhD in the neurobiology of schizophrenia, and also in drug and addiction work too, the things that I published in. So we wanted to start formalizing the team and building capacity within the trust for addictions research. So that started off with some strategic research funding from GMMH, which allowed me to employ initially a senior research assistant and work up some of the studies that we're going to talk about today, and eventually apply for funding that then allowed us to sustain the team and to grow the team and employ other research assistants, and also Nikos as well, who is a research associate who's been with our team for some time now, and is a fantastic member and is going to talk through all the brilliant work he's been doing later. So as well as building this research team through employing dedicated academics within GMMH and within addictions, we've also involved a lot of the clinical staff in addictions research too. And that's been both paid research by industry and also our NIHR funded program as well. In particular, we've had several psychiatry trainees, so core trainees and higher trainees in the Northwest and within GMMH, work with us as sub-investigators on the Care study, on the OPS study, which is the schizophrenia detoxification study I'm going to talk about, and also a new study called Gamer CAMS, which I'm also going to mention as well. And along the way, we've also collaborated with external stakeholders, including other academic institutes such as the University of Hull, the University of Newcastle, King's College London, Imperial, and others. And also we've managed to do a lot of stakeholder dissemination events locally too, with the GMCA, the Mayor's Office, and various commissioners around GMMH as well. So in terms of the grant funding that we've managed to achieve, well, the EDITH and the VALOR studies were funded to the tune of £190,000. The More Care study is a £1.2 million study. The Wellcome Trust study into auditory hallucinations, which I'm also a co-app on here, and Manchester will be a major site, was £4.2 million. We're involved in a NIHR mechanistic study with another GLP drug that's funded to the tune of 2.76 million, and then several other commercial trials too. And overall, in the last couple of years, we've recruited 100 plus participants into studies. So that's really just an overview of how we've grown the team and the research work that we've been doing in the last few years. So we've got lots of future plans to grow the team, to sustain the team, to build capacity. We have submitted our own Depend NIHR research for public benefit submission. So we're looking at doing a mixed methods evaluation of alcohol detoxification, leaning into our clinical expertise and also our expertise that we've gained over the last few years in mixed method studies as well. So that will be looking at primarily alcohol detoxification and outcomes and pathways, both as inpatient detoxification and also in acute hospitals and psychiatric wards as well, and really just trying to see what's going on, because we get the impression that the quality of alcohol detoxification and access to alcohol detoxification has deteriorated somewhat in the last 5 to 10 years. The other study is a health technology assessment. That's the NIHR HTA. And this is with colleagues at King's College London, and this is looking at contingency management, but driven by wearable tech that measures blood alcohol levels. So that's another grant that's been worked up. We've got to the second stage of a programme grant with Professor Tony Morrison. This is primarily looking at psychosis outcomes, metabolic risk factors, and comparing antipsychotics versus CBT and versus combined therapy in people with first episode psychosis. But we will be looking at some alcohol and drug measures within that as well. And then more recently, we've applied for a grant from the UKRI. They're interested in gambling harms, and we've put in a proposal that's looking at gambling within gaming with some other stakeholders around the country. So they're ongoing applications that we hope will get funded. They may well not, but let's see. We'll keep going. And a new study that we're self-funding is called Gamer Cams, and I also work at the National Centre for Gaming Disorders in London, and there's a real dearth of research into gaming disorder and attitudes towards gaming, knowledge of gaming disorder within CAMS professionals, and a real lack of research into clinical populations with gaming disorder. And obviously in GMMH, we run several CAMS services and have lots of CAMS professionals and trainees too, who are helping out with this study. So we've designed a survey that we'll be administering to CAMS professionals. We've got through the ethics approval and we're almost at green light with GMMH. So some of you may hear about that too. And yeah, we hope to build the case for the fact that we need more research into gaming disorder and probably a bit of a public health and professional education campaign. In terms of our future plans, so we're looking to obtain substantive academic positions and better positions within the University of Manchester, potentially changing ourselves from a research team to an official research unit within GMMH if that's possible. And obviously we need to keep generating further grant income to sustain our research activities and our team. So that's the end of the section where I'm giving you an overview of our team. What we're going to do now is talk about our actual research results. So first, we're going to talk about ketamine detoxification. So we wanted to make the most of the clinical data that we've got at the Chapman-Barker unit. The Chapman-Barker unit is the largest NHS specialist inpatient detoxification unit in the country and has been running for a very long time. So there's a huge wealth of clinical data that's completely unique on the CBU. So within either service evaluation or potentially through research ethics committee approval, we can retrospectively analyze our clinical data. This study, we did it under service evaluation. The OPS study, which I'm going to talk about next, we actually have REC approval for. But either way, it allows us to explore interesting treatment populations, drug-using populations. And as I'm sure most of you will be aware, ketamine appears to be really causing a lot of severe problems for young people in the country at the moment, and in particular in the Northwest. So we were interested in seeing who are these people that are being admitted for ketamine detoxification, and what are their outcomes. So this slide shows that since 2016, I want to say, but it might be 2017, we've had 59 ketamine detox admissions. The majority were polysubstance users, although usefully we've also had 23 people who are ketamine only admissions, which allows us to really focus in on the ketamine related harms. There's a slightly more males than females, as you can see here, so 59% male, 41% female. But that's probably quite unique, that ratio, in that compared to our treatment-seeking alcohol population, there's a much more even gender split when it comes to people being admitted for ketamine detoxification, which I think is fairly new in this kind of service. They tend to skew young as well, so you can see our age range is from 17 to 45, but the mean age is 25. People are typically admitted for 2 weeks. They're typically inhaling ketamine, and as you can see, about 80% of people complete their detox successfully. Well, I can't leave this slide without pointing out that is Andy Burnham, who came to visit our units a couple of months ago. We recently renovated a large part of the CBU, and he came to cut the ribbon and reopen it, which is great. Okay, so yeah, as I said, the period of time that we did this study between is 2016 and 2025, and what you can see from this trend of admissions here, so these are our numbers of admissions for ketamine detoxification each year. You can see that there's a significant increase between 2016 and 2025. And in fact, there's a really significant increase from 2023 to 2025. So we've already had 21 admissions for ketamine detoxification this year, whereas back in 2022, it was only 14. So that's a significant increase. So something is changing in our treatment-seeking population. We wanted to characterize the withdrawal symptoms for ketamine, because this also isn't particularly well documented. Again, we're dealing with routinely collected clinical information here, so this is messy data. Some of these people will have been using other drugs as well, and not everyone had their withdrawal symptoms described. But broadly speaking, you can see here that people describe craving as one of the main withdrawal symptoms, and then anxiety, agitation, and sweating. So we were also interested in whether there was a dose relationship between the lower urinary tract symptoms that I'm sure you'll all be familiar with or have heard of, that people experience when they've got severe ketamine dependence. So that urge to pass urine more frequently, that painful passing urine, the abdominal pain. We wanted to see whether there was a relationship between that and dose. And broadly speaking, there is. So the more ketamine you use, the more likely you are to have lower urinary tract symptoms. And something that isn't talked about in the literature that much is the fact that there also seems to be a kind of hepatitis type picture, in that people have raised liver transaminases. They don't tend to have raised bilirubin or those signs of decompensated liver failure that you see in people with alcohol dependence. But there's definitely something going on with how ketamine is metabolized in the liver that seems toxic. And then we're going to explore this in more detail, because at the moment we've just focused on ALT, but we'll also be able to look at some of our other LFTs to really kind of characterize the kind of hepatic pathology that goes on there. So that's a kind of next stage that we'll be doing. As you can see, that if we look at the sort of fourth row down in our ketamine only users, so n equals 20 there, you can see that the people that have lower urinary tract symptoms are using at a higher dose, and the vast majority of people do have lower urinary tract symptoms. Of course, there's a bit of a selection bias, because people will only really be referred to the CBU because they have more severe complications related to ketamine. So this is all preliminary data, but it's an indication that there's a dose response there. And you can also see with the ALT, it does tend to be raised on admission, and that is associated with a higher dose, but it is also raised on discharge too. So it persists, and that is also associated with a higher dose at baseline. And again, this is just exploring the relationship between the admission ALT levels, so that raised transaminase, and you can see that the mean transaminase is 103. The reference range should be under 40, so the majority of people have an inflamed liver, and actually that seems to increase during the period of detoxification. So something's happening to the liver over those 2 weeks that we don't quite understand yet. And just the statistics that are here tell us that there is a difference between the mean admission ALT and the discharge mean ALT, but there isn't a predictive relationship between the mean baseline ALT and the discharge ALT. So in conclusion, there's a significant increase in treatment-seeking young people with ketamine dependence who have severe medical complications. The ketamine bladder symptoms appear dose-related. We're not really sure of this mechanism behind the raised transaminases in the liver. We have really successful detoxification rates. Unfortunately, we really do lack treatments into the targeting of craving and relapse prevention, so that's really a big area for future work. There's maybe a little bit of evidence for naltrexone. There's a kind of hypothetical evidence for acamprosate, but there's only really case report level data to guide prescribing at the moment. So more research needed. Okay, so this is our another CBU based study where we've selected people who have a diagnosis of schizophrenia and are undergoing opioid detoxification. So we know that co-occurring substance use with schizophrenia is really, really common. And that's kind of when you include all the different substances that people can potentially use. And we know that increases risks of hospitalization, of mortality, of suicide, and also it makes it really hard for people to access services as well, because people get passed from pillar to post. And the Royal College of Addiction, the Royal College of Psychiatry's COSUM report was hoping to address some of these issues, which I recommend everyone reads. So we know people with schizophrenia who have substance dependence have really poor outcomes and really struggle to access treatment, but they're not really studied either, and that's probably because it's also hard to do research in people with this combination of problems too. But that doesn't mean we shouldn't try, and that's why in a way, you know, the data set that we have on the CBU is so important, because we probably have one of the biggest data sets that's going when it comes to people with severe opioid dependence and schizophrenia. So yeah, we know drug-related deaths are higher in people with schizophrenia, and there's a real dearth of evidence to guide prescribing and treatment. So we wanted again to look at people who had opioid detoxification on the CBU with schizophrenia, and we did this by looking back over the last 10 years pretty much, and we wanted to see whether their treatment, whether their characteristics, their drug use characteristics and their treatment outcomes were different to a group of people, a group of controls essentially, who we matched by age and gender, who didn't have schizophrenia but were undergoing opioid detoxification, just to see if there are any differences, anything interesting that we might find out. And I just want to do a shout out to Dr. Bamford, who did the vast majority of the data collection and data analysis for this study, which I think is really interesting. So you can see here that when it comes to demographic backgrounds, we've got a fairly similar group of people, whether you have schizophrenia or not. And you can also see that there are quite high levels of people having previous custodial sentences, some people on probation, and also high levels of trauma as well, which again I think is a really under-researched area in people with psychosis. We talk a lot about trauma-informed care in addiction services, but I think we need to talk about it a bit more in schizophrenia services too, in psychosis services. So this kind of tells us that in terms of demographics and some of the risk factors, the controls and the people with schizophrenia were similar. So then we wanted to see whether having a diagnosis of schizophrenia meant you were more or less likely to complete your treatment. So whether you were more or less likely to successfully detox from opioids or opiates. And whilst the majority of people did detox in both groups, well, you were less likely to detox if you had a diagnosis of schizophrenia. So from this data set, we're able to say that treatment outcomes for people with schizophrenia are poorer than those without schizophrenia when undergoing inpatient detoxification. And we're in the process of trying to determine why that might be. We're looking at rates of antipsychotic prescribing. There are some interesting things around the medications used and PRN medication, and also whether there's a relationship to dose. So from this preliminary analysis, we're able to say that individuals with schizophrenia were less likely to complete their inpatient detoxification. As I alluded to, when we did a subgroup analysis of patients, of within the patient, so not in comparison to control, it seemed that clozapine, long-acting injectables, so depot antipsychotics, and also antipsychotic polypharmacy was associated with higher completion rates. So there's something about antipsychotic medication being optimized either before or during inpatient detoxification, which is obviously something that we can do on the CBU, but it's probably something that we need a bit more time to do as well. And there's often a pressure to reduce treatment durations of inpatient detoxification because it's expensive and people are thinking about costs. But for this population, we probably need to take our time when it comes to detoxifying people. Also, and in particular, as the second point mentions, those with a higher who are on a higher dose of methadone, because we know that it's, you know, the higher dose you're on, the more difficult it is to detoxify, and the longer you really need to do that successfully. And ultimately, you know, we need integrated multidisciplinary care pathways that address both psychosis and substance use disorder. And I know there are attempts to do that within the trust as well, but we need to get better nationally. So finally, I'm just going to summarize the clinical trials and other studies that we're involved in too. We don't have enough time to go into all of these in detail, but I'll summarize them quickly for now. So I already alluded to the NIHR More Care study. So this is being led by the University of Exeter, and we received, as I said before, £1.2 million of NIHR funding to run this study. We've got 8 sites across the UK, and locally, Dr. Tracy Myton is the PI in GM, and we were actually the top recruiting site in the last 6 months. And so this study is a double-blind randomized control trial, a phase 2 study where people with alcohol use disorder or alcohol dependence get randomized to 2 treatment arms. One is a higher dose of ketamine given as IV infusion, and the second arm is a lower dose of ketamine also given as an IV infusion. So one of the difficulties within clinical trials of these kinds of compounds is that it's often quite easy to unblind yourself. So there's a debate about what the control arm should be. Sometimes they use midazolam, but in this trial, both groups get ketamine, just at different doses. And so we're interested in seeing whether these infusions of ketamine at a higher dose or a lower dose have an impact on alcohol treatment outcomes, such as heavy drinking days abstinence, and these kinds of things. So that's ongoing and will be carrying on until 2026. I'll just go to the forward study. So this is something that Dr. Dewhurst has been leading on with Anne Lingford Hughes and Imperial College, which is a study that's looking at using baclofen, the GABA B agonist, to help people reduce or withdraw from methadone in the community. There's some evidence it can help with withdrawal symptoms, and I think we've been doing very well with that study too. We may even have over-recruited, which is great. And then Dr. Myson is also the PI for a Breaking Free Online trial, which is a psychosocial intervention to help people into recovery, which is ongoing as well. I'm going to talk about the Lily study next, because this is a really exciting new, 2 new studies that are hopefully being set up in the trust. The alcohol use disorder definitely is, and the opioid use disorder is highly likely to be set up too as well. So you'll be aware of medications like Mounjaro and Wegovy, these GLP-1 agonists, these incretins that are used to help people lose weight. Well, there's some evidence that these compounds, whilst they act on the guts, they also act centrally in the CNS too. And anecdotally, and some early trial evidence suggests that people who are enrolled into these studies for weight loss also tend to reduce their alcohol and other drug use too. So this study is really a big multi-center international trial where Lilly are seeing if one of their new compounds that acts in a similar way will help people to reduce their alcohol use or their opioid use too. And so keep an eye out for that. We'll be setting those up over the next few months and recruiting soon. And then finally, a study that again leans more into my previous PhD work actually, and my work in psychosis. We are a site for this, testing a computational model of the role of cortical circuits in auditory hallucinations in people with psychosis. So broadly speaking, this study is interested in exploring the hypothesis that excitation and inhibition are important in the generation of auditory hallucinations in people with psychosis. So you have a mismatch between the cells that switch on neurons and the cells that switch them off. We have GABA being the main inhibitory interneuron in the body, and glutamate being the main excitatory neurotransmitter. And so we're using a computer model and also different biomarkers to explore excitation and inhibition in people who hear voices, using fMRI and EEG, and also a novel compound called AUT00206, which activates these GABAergic interneurons, and we think maybe enhances inhibitory function. So that's a clinical trial. Well, it's not a clinical trial. That's an interventional study with a novel compound, and it's a collaboration between Tiffany, Wellcome, King's College, UCL, and Manchester. All right, I think that's me done. Yes, over to you, Nikos. Thanks very much.
Thanks, everyone, and thank you for being here. I'll try to keep it brief so we can have some time for questions. So in this point, I'm going to discuss the value of outreach study, the VALOR study. So we worked with a wide range of partners in this study. The Mental Health Implementation Network that was based in South London ARC, and a range of universities and NHS trusts. It was a really wide project about alcohol assertive outreach treatment in London, York, and Hull, and Manchester as well. So the focus of the study was alcohol assertive outreach treatment. The roots of this intervention are traced back to the model that a lot of you will be familiar with, the assertive community treatment model that was introduced in the 70s in the United States, with the aim to prevent the rehospitalization of patients with severe mental illness. So the aim of that model was obviously to work in an outreach-focused way to support people in a long-term treatment in order to promote their engagement with mainstream services, but also to prevent their increase in healthcare utilization. So the alcohol assertive outreach treatment intervention is a development of that model for people with alcohol dependence. Now, the model has been evaluated before in various publications. The publication by Hughes and colleagues was published in 2013, focused on the Salford Alcohol Assertive Outreach Team, which was one of the services that we evaluated in our study. And of course, we have the trial, that pilot trial that happened in 2017 by Colin Drummond and his colleagues. And a more recent trial has been completed in London by Professor Drummond and great colleague of mine, Amy Wolstenholme. We are awaiting the results of that study to be published very soon. So in our study, the two services that participated were the high impact substance misuse team in Salford, which is what is considered a high quality model of assertive outreach. They tend to work with clients for longer periods of time, and the Big Life assertive outreach service that is operational in Salford and Bolton, and they also work in an outreach way, but there are some differences in terms of they cover a massive group of people, and that also means that they work for a less period of time, focusing on increasing the engagement of their service users with the main addiction provider, which is Achieve GMMH. So we wanted to characterize the population and want to see things that have to do with the healthcare utilization of these patients, and of course what really worked in their engagement with this service. And of course we did an implementation science kind of study to see what really promoted and hindered the sustainability of the intervention in Greater Manchester. So as you can see here, we had some interesting reductions. We did a pre and post design. So you can see that the higher quality model, which supported a quite smaller group of people, had some significant reductions in A&E attendances, but also we had some reductions in the big life version of the model, which obviously covered a vast group of people. We also did a subgroup analysis for people who had higher healthcare utilization at the baseline level, and you can see there that differences are quite distinct. And of course, we also examined unplanned ward admissions, which is in general the principle of the model is aiming to reduce the healthcare utilization. This is visible in both services, especially for the groups that had a higher healthcare utilization in the baseline level. Now, we did a few interviews with service users, staff, and stakeholders. Our first part of the study focused a lot on engagement, and we asked what the staff members thought and what the service users thought promoted the engagement. But before that, and very prominent theme in our interviews was that the multiple complexities experienced by these service users really prevented them from engaging with mainstream services. Stigma was something that was highlighted quite frequently in these conversations, the stigma that people experience in their encounters in healthcare settings, but of course the multiple complexities that have to do with trauma, dual diagnosis, difficulty in mobility, and other needs that are not really met. Now, we asked the service users and the staff what they thought was the reason that they engaged with the alcohol assertive outreach treatment model, and the main kind of finding was that the difference in approach, the less bureaucratic, less technocratic approach that staff members were using in their assertive outreach intervention was really important for this group. The idea of a human approach was something that was very interestingly mentioned a few times in our interview data. We did interviews with 18 service users and 20 members of staff. We interviewed all members of staff working in these services. We also explored what they thought, the service users thought it was the relative advantage of AOT in comparison to the mainstream services offered, and of course the outreach element was very important, but also interestingly the service users were very clear that the ability of the outreach service to provide immediate contact following hospital admission, for example, that was really beneficial, and obviously hospital admissions for this kind of group always function as teachable moments, which creates the opportunity for services like assertive outreach to intervene at this setting. And of course, the clinical outcomes that were reported, apart from the reduction in healthcare utilization that we saw earlier, there were some references to achieving abstinence, especially for people who were working with assertive outreach for a long period of time, but also some of them had some important reductions in drinking alcohol in a less chaotic way, another very popular word in our interviews with service users. And of course, we explored things that have to do with the implementation of the model. Obviously, the positive team culture was extremely important. There was a general focus on promoting learning with these services, primarily because of the wide complexities that this group experiences, which requires multidisciplinary input in order to be able to address those needs successfully. Of course, there were some barriers that have to do with the short-term funding of substance misuse services across the country, as you know, and of course, the limitations that this puts on the question of multidisciplinary input. How many members of staff can you have? How many psychologists, social workers, and so on and so forth. strong partnerships between the assertive outreach service and the acute hospitals were highlighted as extremely important. As I mentioned, a lot of these service users are being contacted by the assertive outreach services following a hospital admission, but also very strong partnerships also with the community drug and alcohol teams. That's why it was very important that we had the Big Life service subcontracted by GMMH, who was also running the main addiction service. And of course, there was a lot of focus in providing the data that show that the model works, because obviously these services are constantly under threat of being underfunded, primarily because of different cuts that happen in public spending. Now, we have explored these issues at greater length in 3 publications so far. Feel free to screenshot this. If you struggle to access the articles, feel free to drop an email so we can send them to you. And now we'll move on to the last study that we're going to be discussing today, which is the early detection of liver fibrosis in people experiencing homelessness. It's a study that we completed recently. We received funding for this study by the Manchester Academic Health Science Centre. And we collaborated very closely with the university and Bolton City Council, and of course the rough sleep, drug and alcohol team, which was the place where the pathway that we explored was based. Obviously, as you know, liver disease is a significant health problem in the UK, particularly also in the Northwest. We have the highest number of alcohol-related liver disease hospital admissions in this region, and of course the number of deaths across the country due to liver disease keeps increasing. Of course, the thing about liver disease is that it is what is often called the silent killer. I wanted to mention also that there is an idea that the early detection of liver disease can be a part of a comprehensive addiction treatment program, so that you can have conversations about harm reduction with service users while they're being scanned. Obviously, people experiencing homelessness have a much higher mortality ratio in comparison to the general population. It's also a group of service users who struggle to engage with mainstream services due to stigma and other barriers. So it is really important to promote the early detection of liver disease in this cohort. So in that sense, the rough sleep, drug and alcohol team of Salford and Bolton in GMMH created a pathway that was involving the scanning of all service users referred for alcohol use disorders, but eventually also for other substances, with transient elastography. It's, as some of you know, often mentioned as the FibroScan, which is the name of the device that is being used. So service users who had the F4 score, which is like the highest score of fibrosis for people with liver disease, were referred to the hepatology departments of the local acute hospital. So we did basically an implementation science study of the pathway, conducting interviews with service users, all the staff members of the assertive outreach teams, the rough sleep, drug and alcohol, and of course the various stakeholders that are involved in the implementation of the pathway. So very quickly about the different results that we found. So in terms of the service user experience, we obviously found that there are multiple vulnerabilities involved in this cohort, which really prevents them from engaging with their primary care and in acute hospital settings. Stigma was something that was frequently mentioned, and that led us to do a separate analysis on stigma-related data of this study as well. And obviously issues that had to do with health literacy and IT literacy was something that was really important. Obviously, we asked the service users what they thought really helped when this pathway was implemented, and the offer of an assertive outreach methodology in bringing the service user to the scan, reminding the scan to the service user was really important, but also the person-centered way. This team has very experienced substance misuse practitioners who really know how to speak with this cohort and try to engage them in harm reduction. And of course, we also explored with service users what they thought about the conversations they had with the nurse that was conducting the fibroscan. Maria, I'm not sure if she's here. Maria was really fundamental in setting up this pathway. Maria Waltz. But in general, we had some interesting reactions of service users in terms of the results they got. Some of them were surprised when the results weren't so bad. Some of them were quite happy. Some of them thought that it's an early warning, but they took the feedback quite seriously. And then we asked about the implementation of the pathway in terms of setting it up and designing the service. There were some concerns about the cost of the training and how many people could be trained to deliver the scan. That was something that was mentioned. A general concern about the stigma around substance misuse and homelessness that affects how well these services can be funded and how sustainably can be funded. There were some concerns that basically people who are in positions of political power are considerate of the public stigma against addictions, which obviously limits their capacity to promote more spending for these services. But of course, there were some facilitators of implementation which had to do with the staff motivation and obviously the drug and alcohol rough sleeper grant that facilitated services like rough sleepers drug and alcohol team in Salford and Bolton. The support from Chapman Barker unit when clinical space was required, and also to support the recording of this pathway and the scans that took place was also extremely important. In general, after doing 2 studies in alcohol assertive outreach services, we have come to the conclusion that basically we can see them as strategies that try to address an apparent mismatch between a service user cohort that requires high shelter utilization. They frequently go to A&E with multiple concerns, but also the perceived limitations of these services to meet their clinical needs. So that was something that we definitely need to highlight in advocating for this alcohol and drug and alcohol assertive outreach services. Stigma was implicated not only in terms of the experiences of service users with healthcare professionals, but also in how these services are being funded. That's something that a lot of staff and stakeholders mentioned. And of course, the need to promote the understanding about the clinical management of the concerns of this population is extremely important in terms of their encounters with primary care and hospital staff. We have prepared 3 publications for this study. The first one has been accepted and it's actually in press. We're going to be having it very soon, and the other 2 are under review or with the editor. I would like to thank everyone who has been involved in this study. It would take at least 3 or 4 hours to explain how everyone here has really supported this process, but thanks very much for this. Now over to you, Dr. Kaar.
Okay, yeah, thank you, Nikos. Yeah, and just to reiterate what Nicholas was saying, this was a huge team effort. So we're really, really appreciative to everyone that's helped us, both in terms of the R&I team, our academic partners, our commissioners, and our clinical services as well. So thanks for that. So just to summarise briefly then, as you can see, addictions research is growing in GMMH, and we hope that we've built a sustainable team and increased capacity within the department, and we've built links between GMMH and, solidified links between GMMH and the University of Manchester and other academic partners. In terms of our research results, so we can see that ketamine related admissions have been increasing significantly over the last sort of 2 to 3 years, and that these admissions and this ketamine dependence is associated with significant harms. There are clearly inequalities in treatment outcomes for people with schizophrenia and opiate dependence, which require further exploration. I think it's a really under-researched area. And as Nicholas has been saying, it seems that assertive outreach models for people with substance dependence are highly acceptable, really, both in terms of the staff running them and the service users who are being helped by them. And the evidence seems fairly conclusive that it reduces hospitalization and harms and is likely to save money, although I think we need to do some further work around that too. And undoubtedly, early detection of liver fibrosis using FibroScans is the way forward, and we should integrate FibroScanning into all addiction services, really. So we hope to work with commissioners to continue doing that. And that's it. I think we have about 9 minutes for questions. So over to you, Emma.
Thank you so much, both of you. So I'll kick off with first question. What do you think the main drivers are for the increase in admissions for ketamine detox?
Yeah, I'll answer that one if that's all right.
Yeah.
So I think ketamine, the prevalence of ketamine use has been growing and is, according to some surveys, it's, the second or third most popular drug used by young people. So I think it's become culturally much more acceptable and much more commonly used. And I think that's been increasing over years. I think that kind of cultural acceptance of ketamine use and in conjunction with what seems to be a complete collapse in the price of ketamine and massive increase in the availability and accessibility of ketamine has created this really toxic situation where people are becoming severely dependent on ketamine and then developing these considerable physical harms. I think the reason why I put my declaration in there is because obviously I'm also involved in using ketamine as a therapeutic agent as well. And I think, both things can be possible. Ketamine can be used therapeutically in the right situations, with the right safeguards and controls. But I think the people that are becoming dependent on ketamine are probably, in some respects, the people that would have suffered with dependence to other substances anyway. Ketamine just happens to be the substance of now, because the people that we do see on the CBU who are becoming dependent have, a history of loss events, complex trauma, family members involved in substance use too. So some of the risk factors are similar for people developing ketamine dependence. So I think it's kind of a toxic mix of accessibility, low cost, and it's sort of widespread cultural acceptance. Yeah, and people we see are using it to self-medicate often, and then of course once people develop the dependence, they have to keep using because they're dependent, but also because you get this vicious spiral where people have such severe bladder symptoms that they're in so much pain. Ketamine is an effective analgesic, so they're using ketamine to take away the bladder pain, and that makes the bladder pain worse. But we are talking about a kind of severe daily using population, and we can see that there's a dose response in something like the ketamine assisted psychotherapy study. People are getting 3 infusions of ketamine in controlled settings, and that's it. So it's quite different.
This is the More Care study, isn't it?
And that's the More Care study. Yeah. Ketamine assisted psychotherapy, and it's in conjunction with psychotherapy as well. So we're not saying just give ketamine in a kind of uncontrolled way and hope that it helps with depression, or in this case alcohol use disorder. It's actually using it as a way to catalyze the effective therapy. That's the theory anyway. I mean, it might not work, but the early signs from previous studies are fairly promising. This is why we have to do this study, to see if it is actually useful or not.
And on the More Care study, when are you expecting to be able to publish results or findings of that?
Yeah,
what's the timeline?
That's a good question. We're a little bit, well, even though in Manchester we've been doing really well with recruitment, overall, for various different reasons, recruitment has gone a bit slower than anticipated. There were delays in starting the study for various bureaucratic reasons, so we're a little bit behind. We've actually got an extension by a year, so we will still be doing the study, we think, this time next year. Hopefully by that point we'll have collected enough data to then start closing the study and analysing the data. So realistically, we're not going to know anything until at least 2027, I would say.
We'll have to invite you back to explain more to us as you get closer to that point. Fantastic. I think that's probably all we've got time for. I've not seen any other questions come through. Right. So this is just very quickly how you can get in touch with us. If you email us at Ask About Research, we will pass those questions on to Stephen and Nikos. If you need us to, it's just a good central mailbox for us to get in touch with the various teams and resources that you might be looking for. Our website also has a huge range of resources, especially our active studies finder, which is basically a library of our recruiting and open studies. You can find out more about what's going on with them, which ones are recruiting and for who, look at some of the patient-facing documents to see if that works for someone you know, someone you're working with, and who you can get in touch with to ask more. We also publish some of our findings and our publications on our social media pages. So that's a good way to find out what's going on if you give us a follow on one of those. So thank you all very, very much. For those of you who have been taking part in the studies with Stephen and Nikos, thank you so much for your help and support. Stephen and Nikos, thank you very much for your time and explaining what you're doing. It's really, really important and some really pioneering stuff. So thank you. Thank you all so much.
Cheers. Bye. Thank you.